immunogenicity of both conventional and especially particle therapy, and how this correlates to their hopefully optimal combining with immunotherapy. Okay, so I'm sure that many of you are aware of the statements in the literature like this, that many cancers are not inflamed, thus not recognized by the immune system. Well, immune system is not blind and is very aware of the tumor cells since the very beginning, since the first tumor cell was developed, much before the tumor will clinically be manifest. So the problem in cancer is not the blindness, but actually it is the tolerance to tumor that is tumor induced. Okay. Oh, this is changing by itself. Okay, I'm sorry. Okay, so I am also sure that many of you are aware of the immunoediting concept, right? This is a process of interaction between the immune and cancer cells, whereby the immune cells can both eliminate and promote tumor development, right? So it consists of three phases that are listed here. First one, elimination phase, in which precancerous lesions are eliminated through the different immune mechanisms. And then the second, equilibrium phase, in which some cancer cells will be held by the immune system on check, preventing it from becoming clinically detectable. You know the famous example of the melanoma patient who was tumor-free. I think this was published in the Name, that was tumor-free for 16 years following the surgery, but then donated his kidney to the receiver, who then developed a metastatic melanoma. The third phase, as you can see here, is an escape phase, where the tumor, practically cancer cells, acquired the potential to evade immune control, finally becoming clinically discernible. So there are two main ways or strategies how cancer cells can evade the immune system. One is by avoiding their recognition through different mechanisms, like silencing or deleting the genes involved in the antigen generation, or down-regulating the antigen processing, or by reducing MHC1 expression, etc. And the second one is by disabling or eliminating immune cells through secretion of the immunosuppressive molecules, or by the recruitment of the immune cells, like dendritic cells, myeloid-derived suppressor cells, that practically actively promotes the tolerance to the tumor. All right. You know well about the famous checkpoint mechanisms, right? CTLA4 or PD-L1. These control mechanisms are operated by the regulatory T cells and the myeloid-derived suppressor cells, and they actually protect against the unwanted or exaggerated immune responses. So any factor that initiates an immune inflammatory reaction will also trigger this control PD-L1, PD-1 pathway, and through recruitment of regulatory T cells and myeloid-derived suppressor cells and release of the anti-inflammatory cytokines will control this reaction and will limit the started inflammatory reaction in order to protect healthy tissues from an exaggerated, potentially damaging reaction. Okay, so the bad news actually is that the cancer cells can adopt and use the same mechanisms, and in that case, the cancer cells are able actually of re-educating and reprogramming the regulatory T cells and myeloid-derived suppressor cells establishing an immunosuppressive tumor microenvironment. And that is the real problem. This is happening through the following mechanisms adopted by the cancer cells, like chemokine release for the recruitment of the myeloid-derived suppressor cells, then their re-education and reprogramming, and production and release of immunosuppressive factors that together can manipulate practically the tumor microenvironment, making from it immunosuppressive, polarized or directed environment. Okay, myeloid-derived suppressor cells based. Myeloid-derived suppressor cells based inhibition of T cell activation, function, and trafficking also is involved, as well as the polarization of macrophages toward more suppressive M2 phenotype. So even more, the myeloid-derived suppressor cells enable tumor growth by supporting neoangiogenesis, tumor cell invasion, and metastasis through the production of the matrix metalloproteinase 9 or vasoendothelial growth factor. So there is also one wonderful example, again, I apologize, of the experiment that shows you, the reference is listed below, that shows you how the freshly isolated tumor infiltrating lymphocytes from the tumor site produce more immunosuppressive cytokines, and they don't respond to the traditional immunostimuli like the same type of the cells that is isolated from the sites different and distal of the tumor one, because they are not manipulated by the tumor. Okay, so another aspect, which is a great paradox, is a bimodality of several immune cells and cytokines that are listed here above, that at the same time can be both immunosuppressive and immunostimulatory. The final scenario, so what will dominate as an effect, stimulation or immunosuppression, in this regard depends on which cells or factors stimulates their release, but I also think it depends on how the treatment, potentially stimulatory treatment, this time radiotherapy, is delivered based on the homeostatically determined immune system activity phase. I will tell later something more even in that regard. Indeed, the tumor microenvironment is a very complex network of opposing forces that we still don't fully understand. I'm again talking about the bipolarity of the tumor microenvironment. Myeloid-derived suppressor cells are the key regulators of the tumor microenvironment, and they are practically invited from the bone marrow by chemokines to homing in solid tumors, where they differentiate into the macrophages, macrophages and granulocytes. So they exert inhibitory effects in terms of the expression of immunosuppressive molecules, resulting in a decreased effector T lymphocytes and increased number of regulatory T cells. Depending on the signals from the tumor or microenvironment, the tumor-associated macrophages as well can differentiate into the M1 or killer or immunostimulatory pro-inflammatory type, or M2 so-called healer or immunosuppressive type that promotes immunosuppression and helps the tumor to grow and later to progress. It is known that the cancer cell-derived G protein-coupled receptor 132 ligand can educate actually the macrophages to become functional immunosuppressive M2 type. Why I cannot move it? Yes, I can. I'm sorry. So here is a great example of the suppressive power. Yeah, I'm sorry. Give me, yes, I'm sorry for that. So based on the tumor microenvironment, okay, the tumors can be characterized by the different immunotypes that have been showed on this slide. So they can be immune inflamed or hot, or immune desert or cold. In those hot tumors, the inflammation is present and there are tumor infiltrating lymphocytes present, mutational burden is high, and these tumors produce usually high amount of the neoantigens. That's why they are immunostimulative, and they express also the PD-L1 and respond to immune checkpoint inhibitors, and also show all pro-inflammatory cells in their environment, like T helper 1 or M1 phenotype macrophages or CD8 plus killers. The cold tumors show all opposite characteristics to those that have been displayed here for the inflammatory ones. So the reason for being cold in the tumor are the lack of the tumor antigens through the silencing and deleting the genes, down-regulating the antigen processing and reduced MHC1 expression. So further, the tumor is cold also because of defect in the antigen-presenting cells, absence of the T cell activation, infiltration, or deficit in homing into the tumor bed. All this is done by the tumor in terms of this promotion and establishment of the immunosuppressive microenvironment. I'm sorry, I did something before that my slides automatically changed, so I have difficulty with that, but it's all fine, under control. So based on this, the type, density, and the location of the immune cells within the tumor site, there is a so-called TDL, prognostic immune classification, that was developed and validated for the certain tumors like the colorectal carcinoma or the melanoma. And this can predict survival, local control, or even response to the systemic treatment independently, or maybe even more accurately to the TNM system. So based on the quantification of two lymphocyte population, CD3 and CD8 at the tumor center and invasive margin, one can form this immunoscore ranging from 0 to 4 to predict survival, like in the example placed on the slide. And so let me now move to the immunogenicity of radiation therapy, okay? It is known, I'm sure you're not seeing first time the table or data like this, that radiotherapy generally can generate immunostimulation, right? All these data come from the preclinical studies, and the concept of in situ radiation vaccine actually relies on this finding. So it's a long list of potentially stimulative immune effects published so far in the literature. These are listed in the table in front of you, and these represent the rationale for combining the radiotherapy with the immune therapy. However, there is also a long list of potentially immunosuppressive effects that are induced by the radiotherapy that are listed in this table here. So which effects finally will manifest immunostimulative or suppressive following the radiotherapy is a hard question that for now remains not answered. And because the truth, I think nobody knows, and at least in the clinic, it seems that the balance is often shifted more towards immunosuppressive manifestations, especially if the conventional way of radiotherapy is used. So probably the final effects depend on how radiotherapy is used in terms of the radiation type, technique, dose, timing, or volume to be irradiated, okay? So if the radiotherapy characteristics are concerned, the particle therapy seems to offer a large spectrum of potentially favorable characteristics that might optimally combine with the immune therapy compared to the photon radiotherapy. You have already heard so far in this meeting that particle therapy offers many physical and biological advantages generally over the photons. In terms of resulting in immunostimulatory effect, compared to the conventional radiotherapy, Particle therapy can better spare the immune cells like circulating lymphocytes, like local regional antigen-presenting cells, tumor-associated macrophages, tumor-infiltrating lymphocytes, all these things that we need for the mediation of the immune effects. So these great data from Durante that are here below from more than 20 years ago, but also from the other investigators later, show that carbon ion therapy results in much less lymphopenia compared to the photon therapy. And further, carbon ion therapy shows several biological advantages in terms of the immunostimulation, like to result in the different cell death patterns, like apoptosis, necroptosis, or ceramide PET, increased antigenicity or increased adjuvanticity that are all immunogenic, resulting in the immunostimulation. Indeed, radiotherapy is able of inducing so-called immunogenic cell death, right? Which is the radiation-induced cell death resulting in an immune response. It is characterized by the release and production of the DAMPs, the damage-associated molecular patterns, ATP, calreticulin, heat shock proteins, etc., resulting in an activation of tumor-specific immune responses. So radiation-induced DNA damage in terms of nuclear fragmentation, formation of micronuclei, activates the famous CGAS-STING pathway, resulting in interferon-1 production, leading to upregulation of DAMPs, recruitment of antigen-presenting cells, etc., finally resulting in an anti-tumor immune response. So there are no dedicated clinical trials done evaluating combined immune therapy with carbon ion therapy. Thus remains unknown if this combination improves clinical outcome compared with conventional therapy. However, available experimental evidence suggests that carbon ion therapy has a higher immunogenic potential compared to the photons and protons even. So basic research on carbon ion combined with immunotherapy is still limited to experimental models. But however, these results show that even with the lower doses, carbon ion radiotherapy has substantial potential to activate the immune system. In a mouse studies, carbon ion radiotherapy correlated with stronger immune activation when paired with dendritic cell injection. Combined carbon ion with immune therapy demonstrates increased anti-tumor immunity and reduced the number of metastases compared with radiotherapy or immunotherapy alone, or in combination with photon radiotherapy. There are also preclinical evidence additionally of this kind that are available, like the one from Helm and others published in 21, that you see here, showing again that combination of carbon ion therapy and immune therapy was superior in determining the systemic anti-tumor immune effect measured as a reduction in the number of the lung metastases, compared to each of these treatment modalities separately, or if combined with the photon radiotherapy. However, while some clinical trials using photon radiotherapy demonstrated increased patient survival when immune checkpoint inhibitors are delivered after chemoradiotherapy, the example of famous Pacific trial, etc. There are other trials like these displayed below here that gave disappointing outcomes, like those published in the head and neck studies in series. So the question is, if there is an issue regarding the radiation dose used, treatment sequencing, timing of delivery, or even radiation from radiation form that has been given, okay? Regarding the radiation dose, I have started to talk about that in my previous lecture. Let me add some evidence on this and express my opinion. So There is a debate regarding the most immunogenic radiation dose currently, okay? Many studies have been performed so far, all good studies and evidence, but pretty contradictory data, apparently contradictory, must not be like that, okay? So while ones provide evidence that a very low doses are immunogenic, others claim that moderately hypofractionated or high ablative doses should be used when immunostimulation is concerned because are more immunogenic than others. I think the truth is somewhere in the middle. I think what can be concluded is that different doses from low to ablative can all be immunostimulative and possibly trigger different immunostimulatory mechanisms. In my opinion, there is no most immunogenic radiation dose in that form we would like to have it. You know, one number, again, that can be used for each treatment, for each patient, resulting in the most of immunostimulation. I think this dose is individual, and because it depends on many different individual factors like the tumor type or differentiation grade or timing of the delivery or status of the microenvironment and who knows what else more. So here is how different radiation doses can affect the immunogenic radiation potential. It is known that the reprogramming of the tumor-associated macrophages is achieved using low-dose radiations in range between 0.5 and less than 2 gray per fraction. But the destruction of the tumor vasculature, you know, endothelial apoptosis, is induced by the higher doses using from 8 to 10 gray per fraction. Finally, a recently published study, very nice study, showing how the Tregs-1 path can practically abrogate the SIGA-STING activation and downstream interferon-1 production, practically simply blocking the immunogenic cell death. Regarding the timing of radiotherapy delivery, it plays an essential role in terms of pre-existing immune status and also homeostatic immune oscillations. I'm not talking here about the combination of radiotherapy and immunotherapy in terms of sequencing and timing, but about the time when radiotherapy is used as immunostimulants has to be delivered depending on homeostatically determined pre-existing immune status in the tumor microenvironment. If you give the radio, this is now example that you see here, reference below, that demonstrates at best the matter of timing of radiotherapy. If you give radiation as immune stimulus after antigen delivery by vectors or release by radiotherapy, subsequently given radiation as immune stimulus will mature dendritic cells, resulting in improved ability to generate superior immunity and tumor rejection. But if the dendritic cells are exposed to radiation prior to the delivery of antigen by adenoviral vectors, like in this experiment, it does opposite effect, will block their ability to generate immunity. The same effects can exert also radiation-induced cytokines, depending on time of their release and action on immune system cells. And so these would be my take-home message for you. As you could see, immune system recognize the tumor. The problem is else, and that's that the tumor-induced immune suppression. That is what makes tumor cold, you know. So radiotherapy definitely has potential to break that tolerance and to convert cold tumors to hot. But if we want, this is now my opinion, if we want more from radiotherapy in terms of the immunostimulation, then the radiation features like radiation type to be used or dose or treatment volumes, timing need to be adapted to that objective, especially if the combination between radioimmunotherapy is concerned. So my point here is that the conventional radiotherapy technique simply is probably not the best choice if the immunostimulation is concerned. Many radiotherapy features should possibly be adjusted if we want to reach this goal, to be highly immunostimulative. From the available preclinical data, it might be observed that the carbon ion therapy might be superior compared to the conventional radiotherapy in terms of immunogenicity, but therefore might possibly be a better partner for the immunotherapy. However, there are currently no clinical evidence for this. I am very excited to see the first data coming soon. This is an ongoing non-randomized phase 2 clinical trial from CNAO, Italy, recruiting still the patients with advanced malignancies where immunotherapy is currently the standard of care. So here the investigators, the colleagues from CNAO, will add hypofractionated carbon ion to immune checkpoint inhibitors in cancer patients that have obtained disease stability with pembrolizumab administered as per standard of care. So more trials like this are needed and probably will be the subject of investigation in the near future that could lead, you know, to the better treatment outcomes in terms of this combination. So now I would be done and would be ready for your questions. Thank you very much.
Okay. Okay, so I have another question. What is the different impact of particle beam and photon beam on circulating lymphocytes? Less lymphopenia. Yes. Do you think this is due to only sparing immune cells or due to the different systematic impact on the immune system?
I think mainly this is the effect of the sparing of the peritumoral tissues, including the blood vessels and the tumor microenvironment. So because, okay, I'm not claiming anything 100%, there might be the possibility that the different type of radiation can result in the different spectrum, qualitative spectrum of the cytokine release following the radiotherapy that might potentially affect in a different way function and number of the pool of the lymphocytes, leukocytes, etc., etc. But mainly what is sure, 100% sure, is what you can measure, and that is the dose within the at the level of the blood vessels that is much higher using the photons compared to one that is delivered to these organs and to the circulating lymphocytes using the particles.
Okay, let's see if there are any other questions. I'm not seeing any hands raised. And I'm not seeing any other questions.
Yes, Nicholas, if there are no other questions,
okay,
if I may ask, I did not get it right, I think, about running the trials. Did you say it is in CNAO or you're running these clinical trials in MedAustron?
No, this one. So I'm running the trials in MedAustron using the partial irradiation. But now here, the one that I have presented at the end that try to combine the immune checkpoint inhibitors and carbon ion is in CNAO.
Okay, thank you very much.
Thank you.
Okay, are there any other questions?
Nicholas,
yes, I'm seeing one on the chat. Yes.
Questions that are shown on the screen answered.
Yes, because there were 3 for the previous lecture.
And this last one, because someone is typing right now. What is your opinion on the role of flash effect therapy for
Ah, yes. Okay. Yes, I'm seeing them. Okay. All right. Okay. So does strategies of tumors to avoid the immune system start automatically when the tumor is formed as a characteristic of the tumor, or there are active or there are activated steps related to immune system or other effects?
Let me read this, Nicholas. Let me read this because I was below. I thought I should answer this regarding the flesh, and that I
Okay.
didn't listen in. So let me see.
Yes,
So
yes, of
all
course.
these questions here, right?
That's right.
Yes.
So does strategies of tumors to avoid immune system starts automatically when the tumor formed as a characteristic of the tumor, or there are active steps related to immune system or other? I displayed a wonderful reference on the immune editing. There you have all the details wonderfully, beautifully explained. So you can read that article. This process is made of 3 phases, as I said: elimination process, checking express process, I'm sorry, and then evading. So elimination, check, and escape. And this is something that tumor in interaction with the immune system practically optimize and how to tell, it is necessary, the interaction with the immune system, in order to reach and develop all these mechanisms to evade the immune response and surveillance. Yes, but if you want more details, you can read that article or just type immune editing and you will find everything you need. And is every type of tumor had its proper strategy, and it is related to what? So I don't know exactly, because I am not really the immunologist, but definitely, yes, this is something, the concept of the immunoediting is something that applies to every tumor, not only specific tumors, but to every tumor. So what I've been talking about in terms of immune editing applies to every tumor. How does radiation spare sensor? Is this based on identifying mutant DNA and distinguishing it from healthy one? How could that happen? Thank you. How does radiation spare sensor? But radiation spares the same healthy cells simply by avoiding to deliver radiation dose there where you have the healthy cells. Those healthy cells that will receive the radiation, if the radiation dose they received is lethal, they will die. If it's sublethal, then the healthy cells, compared to the tumor cells, can adopt different mechanisms in order to repair this damage. Some damages can be repaired fully, completely, others not fully, but just partially, so that the cell can survive, but with an failure, with error, which can be the source later of the secondary radiation-induced tumor. What is your opinion on the rule of flash? Yeah, thank you, Esma. On the flash, stop, just okay. On the flash effect therapy for combining with immune, as it could possibly reduce the lymphopenia. Yes, I think simply so. The main issue with flash is that can spare better the healthy cells and tissues nearby the tumor. So this characteristic would just be enough that you say, or that you hypothesize, but needs to be proven. Okay, if it can spare better the local regional immune system cells, associated macrophages, antigen-presenting cells like dendritic cells, infiltrating lymphocytes, etc., this criteria or characteristic should be enough separately to hypothesize, yes, flash can be superior in immunostimulation if combined with the immune therapy compared to the other radiotherapy modalities. Now, if there is something else that flesh, because of this super high dose rate, can add in terms of the mechanisms or antigen processing, if I can say like that, in response, in terms of the response to flash therapy, I don't know this. I hope it can, because that would then probably result or lead to the further improvement in the treatment outcomes. And thanks for this, Ali. Yes, you demonstrate experimental data on immunostimulatory effects of high LET versus low LET. Is this also true for immunologically cold tumors like? Okay, so I don't know, I'm not sure, and it's hard for me. This is number one. It's hard for me to tell if high LET versus low LET matters. I did the treatments with high and with low, yes, but I saw the differences in the outcome, but I don't know actually if this can be related to the high LET versus low LET effect or something else, you know, sparing of the immune system cells, timing of the treatment delivery, partial irradiation, dose, etc., etc. And what was, I don't see, is this true for immune? Oh, yeah. And I have presented the data showing that if you change the form of radiotherapy from conventional to this spatially fractionated, let's say, or partial, yes, you can convert traditionally denominated cold or non-immunogenic into the immunogenic tumors. I displayed an example of the breast cancer. I simply so far didn't treat any glioblastoma, simply didn't have chance to do that with this approach. But I did treated the tumors cold, traditionally cold tumors. And yes, I was able to see and to induce the immunogenic response also in these. Usually people are confused and they are saying, yes, but how can you say that because you are talking about the cold tumors? My response usually is the following. Yes, they are cold. Traditionally, if you use the conventional radiotherapy, whole tumor irradiation, etc., but if you change the form of radiotherapy, if you take care about the tumor-associated immune system cells that needs to be spared from radiation, then you can change everything. Then you can transform tendentially suppressive into immunostimulative microenvironment.
Okay, I think that's it with the question.
That's it. There was a clarification of a question by Esma. Are cytokines diffused from radiated tumor cells are the reason? That was the one of the DNA, but I think that you've answered that question.
I think so, but to be sure, I mean, she can repeat the question.
Esma,
no
can you clarify? Can you unmute yourself and maybe clarify directly? Yes, it was answered. It was answered, yes.
Okay, good.
Okay.
Good. Glad to hear that. Thank you, guys.
All right. Professor Tubin, that was a very lovely lecture, very informative. Both of them were, in fact. And even from the questions that were asked, we see that it was very much appreciated by all the participants. We thank you so much for being here with us today.
Thank you very much for kind invitation. It was my great pleasure. Thank you so much for all questions. Well, it was my pleasure to discuss with you all these topics.
It was a pleasure and also an honor for us. Thank you so much. Bye.
Thank you so much. Bye-bye. Have a good day.
You too. You too. Thank you. Okay, guys, we have a poll. So please answer the poll as soon as possible.